So I titled the talk "Spine Trauma Classification Fake News" because I think that what's the purpose? Why do we even care? What's the reality here? These are my disclosures. Nothing that has anything to do with any of this, despite the fact that I am on AO Spine board. I'm not a member of the Knowledge Forum in Trauma and have not really participated in the development of the classification system. But we want to talk about, let's talk about what makes a good classification system. Let's talk about the limitations of classification systems. And I think we highlighted that a little bit last night, maybe in a slightly too pointed fashion. I apologize. And then we can talk about the motion segment, because I think that's really where this lies, right? I think we get wrapped up in, is it a B, is it an A, is it an A3, is it a 2, is it a 5, is it a 7? And what we forget about is what underlies all this stuff. What is it? What are we trying to communicate to each other? And I think that's, in the end, that's what you want to be thinking about. So why do we classify things? Well, we need to communicate, and so having a uniform method of description of fractures is important. When I get a phone call in the middle of the night from my staff and they say, I've got this guy who was involved in a motor vehicle collision and he's got a fracture or a dislocation, this is what he's got, it's nice if we're all speaking the same language, right? And I'm just going to step back for a second and say, my talk this morning is going to focus on thoracolumbar injuries, but almost everything I say here is amenable to any other spine trauma classification system, other different parts of anatomic parts of the spine. We would love to have a classification system that helps us direct treatment, right? That would be the ultimate. If we could say, this is this, and when you have this, you do this, right? A equals B, C, that would be great. I think because spine trauma is an area where we really don't understand a lot about the natural history and or different treatments, how they affect the outcomes. If anything, having a classification system is mostly important because when we do research, we need to make sure we're comparing apples to apples. And the downfall of the majority of the spine trauma classification systems or the spine trauma literature is that they don't parse out the injuries in a way that's very helpful, that we can really understand that we know what we're treating at any given time. So, a classification system ought to have both clinical and radiological components. It ought to help you get some sense of the severity of the injury. As I said, there should be some guide to treatment, and it needs to be reliable in the sense that when different actors use it, we get the same outcomes each time. And it should have a logical structure so that you can understand it, right? It should be comprehensive, hierarchical, and as simple as possible, because in the past, when we've had classification systems that were overly complex, people weren't able to utilize them effectively because they became confused or they became unreliable in the sense that we got different answers as people tried to get down into the weeds of the classification system. In general, why are we classifying fractures? Because we want to know who needs an operation. And Rick Sasso brought this up last night, right? What we're trying to determine something about the stability of the spine. So what is stability? Stability is the ability to maintain to maintain the spine in a way that does not create deformity or neurologic compromise or incapacitating pain in the face of physiologic loads, right? And the point I like to make to my residents back home is that we're talking about load stability is not a binary concept, right? It depends on the expected load. So for one individual, a fracture could potentially be stable, whereas another, it's not, because the expected loads that they're going to incur are higher or lower. So it may change, our sense of stability may change our treatment algorithm based on our analysis in that way. So here's a timeline, and I'll freely admit that I kind of stole this slide from Alex Ficcaro, that goes through kind of where we are in classification. So, classification systems of spinal trauma have been, oh, look at that, cool, have been around since the 1930s, and people have made a big deal out of, no, look, now we know about the posterior ligamentous complex, but really in the 40s, people were talking about that. So there's very little that's new, and we shouldn't congratulate ourselves too much. Notice that Tilaks is here in the mid-2000s, so it's really a pretty recent classification system, and the new AO system obviously is even, or remember that the iPhone was introduced into the general population right about here. So, so you know, the scale here, you got to kind of keep in perspective. But, you know, even in the 1930s, Bowler talked about a morphologic classification of spine fractures, and Nickel in 1942 stressed the posterior ligamentous complex, or the posterior column, as an important component. Holdsworth had a two-column theory in the 60s, and Tom Whiteside's likewise talked about two columns. Francis Dennis brought us the three-column theory of spinal stability, to my mind, the single greatest step backward in spine trauma that we've experienced in the last century. I think that the concept of the third column, as amorphous as it is, as difficult as it is to understand, has really, we continue even today to talk about the third column, or the middle column, but there's no such thing as far as I'm concerned. And then Paul McAfee, again, used that. The load sharing classifications in 1994, I think, was a response to some deficits in screw technology at the time, and I think has very little to do with what we do these days. Franz Magerl came up with this monster of a classification system, which is really still the basis of the AO classification, and then Tilaks. And that was 2005. And Tilaks has become, I think, the workhorse for most people in thoracolumbar classification, because it is a scoring system as well as a classification system, and it gives people guidance into how to treat things. So as we looked at last night, you have compression, or you have morphology as opposed to mechanism. Morphology, notice that in the thoracolumbar, distraction is the highest level of points, whereas in the cervical spine, it's the other way around. Translation is. We talk about the posterior ligamentous complex, and we talk about neurologic status. And Tilaks, really, I think the great value of it was the first classification system that included neurologic status overtly. We've always used neurologic status as a I think it becomes both. We want to talk about whether there's potential to improve neurologic function, but also it gives you some idea of the energy of the injury, right? If you have two equivalent injuries, but one has a neurologic compromise and one doesn't, it probably means that spine has absorbed more energy enough to disrupt the neurologic elements at the same time. So there's something about neurology that I think is beyond what's the neurologic status in terms of determining injury. But the biggest, I think the two biggest problems with Tilaks are this. In some sense, you count PLC twice, because you can't have distraction or translation without some element of PLC disruption. So you're giving it more points here, and then you're giving it more points here still. So we understand that it's an important element, but you really kind of double count it. And then they have this part of it where they say, well, you have these modifiers. So you can go through your point scale, but then if you have this or you have this or this, you may want to throw the points out and do what you think is right. So on some level, they kind of have this out for things like multiple trauma or coronal plane deformity. So it's not really, or sternal fracture, so it's not really the number that you end up getting can sometimes get thrown out with these modifiers, and I think that makes it a less useful classification system, certainly in terms of using it for research purposes. And again, less than 3, non-operative, 4, indeterminate, and 5 is operative. What are the pros? Well, the pros, it's very simple. There has been some treatment validation. I mean, Tilaks really sits in the realm of expert opinion, grade 5 evidence. There is no randomized prospective study that says if you use this classification system, your patients will have better outcomes than if you don't. But there is expert validation. As I said, it makes you use the neurologic status. What are the cons? Well, it's a scoring system. It's not really a classification system. So there are a lot of 5s, right? And not every 5 is the same. because it can have different patterns. So when you can't really use it for research purposes or literature writing purposes because everything gets thrown into one bucket. As I said, the PLC gets counted twice. And PLC injury may be difficult to determine. And if you look at even MRI scan, and this is a little bit of an older study, 2010, but the conclusion of the study when they looked at the MRIs of people with thoracolumbar injuries is that we really overcall it. So, when we look at the MRI, we may be calling a PLC injury well beyond what is really there. So how reliable, it calls into question the reliability of the thing. Now, this is the AO classification, which you're all should be fairly familiar with, but it goes ABC for morphology, C being fracture dislocations, B being a tension failure on one side of the spine or the other, and A's being anterior column compression type injuries. I think what people miss in AO classification is this part. It really should be CBA. If I had to do this over again, I would make the A's the fracture dislocations, because as you work through the classification, what you're really doing is saying, is this a C? No. Is this a B? No. Is this an A? So people tend to think in A first, B second, C third, but really, because when you subclassify things, you use the other things, but you really want to know, is it an A, is it a B, or is it a C? Really, the top level classification is what's most important. And they have modifiers for neurology, so they take neurology into account, and other modifiers for when you can't tell what's going on with the posterior ligaments, or if there's some specific patient comorbidity, but they're much more generalized than things. And again, I don't know that these modifiers have much clinical relevance in terms of decision making. But I do think that the AO classification is a little better in my way of thinking, because it tells you more about what's going on with the spine. And really, you could almost simplify this even more. If you go around the world and you talk to people who treat spine trauma, what you find is everybody operates on Cs. The vast majority of people operate on any B fracture. And A's are where we talk about whether people should have surgery or not surgery based on whether they have neurologic compromise or canal compromise or whatever. So really, you could make this an AB, right? You could get, I'm not sure you need ABC, because if you talk about how to decide to operate, if it's an A or B, operate. If it's an A, or B or C, operate. If it's an A, you don't. AO is pretty simple if you just stay at ABC and don't get down into the weeds of the subclassifications. It's very thorough. It's more descriptive to me than the Tilaks classification. It gives you more information about the anatomy of the injury. So in that way, I think it's better for research and publications. Tilaks is very simple. It's even simpler than AO. Unfortunately, it lumps many injuries together, but there are fairly well-published algorithms that go along with Tilaks to look at treatment, which would be helpful to people who have less experience in spine trauma care. But when it comes right down to it, I think this is what you need to always keep in mind, right? This is the motion segment, right? This is what we're trying to figure out. And you have ALL, PLL, posterior ligaments, facets, facet capsules, vertebral bodies, disc, right? Don't forget to think about what you think the actual anatomy of the injury is, right? You can use AO, you can use Tilaks. You need to be, I think we should all decide within any institution to be consistent about what we're going to use so we communicate effectively. I don't know that you can say that one of these is definitely better than another. But I think in the end, you need to think on each injury, do I have evidence that the anterior longitudinal ligament is ruptured? Posterior longitudinal ligament is ruptured. Posterior ligaments are ruptured, right? The ligaments are much more to do with stability, right? And that's why A fractures often can be treated non-operatively, because although the bone is broken, it doesn't affect the stability of the segment nearly as much as if you rupture a ligament. So whatever classification you use, don't lose sight of the fact that we're using these classifications to help us to remember what stabilizing structures may or may not be injured, and that's going to help really guide our treatment. Thank you.
So Dan, what do you guys use?
I use the AO classification. I will I will walk in the room and I will say, okay, what is it? ABC, right? I mean, I push my residents to tell me what it is because I think that is, for me, the most clear-cut way to make decisions about what's going on. I will tell you that I still walk in the room and I say, what happened last night? And my resident goes, we got a guy with a flexion distraction injury. And I'm like, stop it. Like, stop using this amorphous, descriptive nomenclature that's not sufficiently specific to help us make treatment decisions, right?
But is that a hospital-wide thing that you all use AO? Do your neuroradiologists say A3?
No.
Do they still call burst fractures a compression fracture?
Yeah, of course. Yeah,
Okay.
yeah, we can't. We're not near that. Unfortunately, we're not near that level of consistency. I wish we were. I wish they were here at this meet. I wish they came to these meetings. Right.
I think that's definitely a thought for the future. Great talk, and we'll revisit that later. Thank you so much, and we'll see you later also. Next.